Thank you once again. So I'll be discussing about this study. So we all know that nowadays oral treatment has almost replaced, and it is now approved as a frontline treatment as well, and in the relapse refractory setting also. So if we see so ibrutinib plus venetoclax is an all oral drug combination which can be used in the treatment of CLL. So this is very important study recently published, and so fixed duration ibrutinib plus venetoclax for first line treatment of CLL, SLL, a 3-year follow-up study, and it is a phase 2 study. Captain, next slide, please. So this is the study design. It is basically 3-year follow-up data from the fixed duration cohort of Captivate study, which is presented, and it's a multi-center phase 2 study evaluating first-line treatment with 3 cycles of ibrutinib followed by 12 cycles of combined ibrutinib plus venetoclax. So these are the almost 160 patients, newly diagnosed patients less than 70 years with good performance score. So initially ibrutinib was given as a lead-in phase with 420 milligram once daily. That is the standard dose. So 3 cycles was given, 28-day cycle, and then after that 12 cycles of ibru-ven combination. Venetoclax was used given as a schedule of ramp-up schedule with up to a maximum dose of 400 milligram once daily. And then after that, the treatment was ended, and then the patient were put on follow-up. And during follow-up, if the patient had any kind of progression of disease, so retreatment options were included, including again continuous or fixed duration ibru-ven combination. So again, it was restarted in terms of when there was progression of disease. So median time of study was 38 months. 92% of patients completed planned 12 cycles of combined treatment, and median treatment duration was almost 14 months. Range was from 6 months to almost 0.54 months to almost 25 months, and which is equivalent to almost 15-28-day cycle. The median of 25 months follow-up or after completion of. So these are the standard characteristics. Almost all kinds of CLL, including deletion, high-risk cases of deletion 17p with TP53 mutation, complex karyotype, and if the median ALC absolute lymphocyte count was 70%. So even high-risk, all group of patients were included in this study. Next slide. So this was with an additional year of off-treatment follow-up. Since the primary analysis, rates of CR and undetectable MRD remain high. So the CR rate in this study of all treated patients increased from 55% at primary analysis to 57% with an additional year of follow-up treatment. And 79% of patients had a best response of undetectable MRD in peripheral blood or bone marrow. And of the patient who achieved undetected MRD in peripheral blood at 3 months post-treatment, 78% of these patients maintained this undetectable MRD level through 12 months of post-treatment follow-up. Next slide. And with an additional year of off-treatment, we can see that the follow-up since the primary analysis proven it continued to provide high rates of PFS and overall survival. So this was treatment free period, and we can see that though the TP53 and deletion 17p and unmutated IGHV CLL patient, they had less PFS as compared to, but long-term follow-up, if you see all treated patients, it was equivalent. But though, as it is expected, these group of high-risk CLL patients had less, and estimated 36-month PFS was 88%. And in fact, in TP53 mutated cases or unmutated IGHV, at 36 months of follow-up, the response rate, the PFS was almost similar. And the estimated 36-month overall survival was 98%, which was similar in TP53 mutated and unmutated. So even in high-risk patients of CLL, the response was maintained in terms of PFS and overall survival. Next slide. And there was another point is because in the inclusion criteria in the study design, we mentioned that the retreatment was also allowed with single agent ibrutinib, and single agent ibrutinib, it it shows the promising response rate, onset, and the resolution of frequently occurring adverse. So retreatment, 12 patients who progressed after fixed duration treatment have been retreated with single agent ibrutinib with duration of retreatment ranging from 6 to 32 months. And out of these, 11 patients are evaluable for response, and these 9 patients achieving PR, 1 patient achieving PR with lymph node persistence, and 1 patient achieving stable disease. And most frequently occurring adverse event was more than 30% of patients were usually grade 1, 2, and are occurred in 4 months of treatment initiation. And usually these are resolved. These are the common adverse: nausea, vomiting, neutropenia, and arthralgias. Next slide. So finally, to conclude, fixed duration improvement continues to demonstrate deep and durable responses in clinically meaningful PFS rate of almost 90% at 3 years, and PFS more than 80% even in those patients with high-risk disease like TP53 or unmutated IGHV. And with additional year of follow-up, no additional overall survival events occurred. The safety profile is manageable and unchanged from that previously reported. Most frequent adverse events were very low grade, and 4 months of treatment is standard and high rates of improvement or resolution. Early data suggests that patients who progressed even after fixed duration treatment, they can be successfully managed when they were retreated with single agent ibrutinib. And ibrutinib venetoclax, it represents an efficacious all oral once daily chemotherapy free fixed duration regimen for previously untreated patient with CLL or SLL. So I will stop here. Thank you.
I request Dr. Vishnu Sharma sir for his expert comments.
Dr. Vishnu sir, you need to unmute yourself, please.
Thank you, Dr. Pawan, for excellent talk. So basically, the CLL treatment has evolved over a period of time, and now time has come where CLL patients will be treated with only oral agents, because ibrutinib, acalabrutinib, venetoclax, all these drugs are effective in TP53 mutated patients, IGHV unmutated patients, and the combination of ibrutinib plus venetoclax will be standard of care because of its beauty of fixed duration treatment. And for the mantle cell lymphoma, I think the combination of this ibrutinib plus this plus bendamustine rituximab will be standard of care in patients who are not eligible for transplant, even in patients with the presence of deletion 17p or TP53 mutation. So thank you for sparing your time and excellent talk. Over to you, Dr. Jitendra.
Thank you so much, sir. Thank you, everyone. Thank you to the speaker. I would just like to add one point that in mental, if at all patient is not affordable for a transplant or not fit for transplant, I do believe that Arasi-based therapy will give us a deeper response. So probably that also one thing which should be kept in mind. And then I will held the mic to the organizer. Thank you, everyone. Good day.
Sorry to interrupt. There is a question in the question answer box. So will you be kind enough to make some comments or answer that? Not in the chat box, in the question answer box. Regarding the CLL, so anybody can take that question from the previous two speakers.
Which marker is good prognosis in CLL and which is poor prognosis? This is for Dr. Pawan. I think he has left. So basically, the presence of mutation of TP53 or presence of deletion 17p and unmutated IGHV, these are the high risk factors for CLL patients, and preferably these patients should be treated with novel agents like ibrutinib, acalabrutinib, or combination of ibrutinib plus venetoclax.
Dr. Vishnu, like the markers previously, which we used to read like JEPS 70 or others, do they have any relevance as on today?
Sir, I don't think there is any relevance of doing these tests because everything is based on molecular mutations. So presence or absence of deletion 17p, presence or absence of mutation of IGHV status, these are the two important things. And CLL-IPI also includes beta-2 microglobulin, the RAI and this RAI staging system also.
Thank you.
So can we invite the next speaker, please, Dr. Somani, sir?
Yeah, please go ahead. Please go ahead. We are waiting.
So is
Yeah,